Good day. We would like to welcome everyone to this, the TMIT National Research Testbed webinar number 115. We've now been delivering these for 115 months in a row. We're in our 10th year, and we're delighted to have the topic Workplace Violence, a Critical Patient Safety and Caregiver Safety Issue. And today really emphasizing the caregiver part. I am Charles Denham. I'm the chairman of TMIT. I will be our host today and move through a number of topics very quickly so we can get to our world-class group of speakers. First off, what I'd like to do, I'm on slide 3, is make sure that you have your audio settings on full on your speakers on your computer, as well as the audio setting on WebEx at max, and your computer volume. Now, if you have a problem, and I'm on slide 4, and you can't hear with good audio, please click on Participants, and then click on the Request Phone icon, lower left corner of your screen, and we'll give you a landline or a better line to help you. I'm on slide 5 now, and a reminder for those that have logged on but have not downloaded the slides, that if you go to safetyleaders.org, www.safetyleaders.org, look in the upper right-hand quadrant of the landing page and click on Upcoming Events. And when you click on the Workplace Violence, a Critical Patient and Caregiver Safety Issue topic, click for details, you'll be able to download the slides. I'd like to also remind you that later, for those that are watching this on demand, that we'll be adding resources to the page as time goes on and give you the opportunity to watch the program and download updated information. When you click on that link, and those that do have the slides, on slide 6, you'll see the page that you land on, and we will put federal reports like the GAO report and others on this page that refer to workplace violence and any information that we think might be valuable for you. On slide 7, you can see our social media links, which we are going to activate in a much more aggressive way in the months to come so that we can refer people back to these webinars. Our purpose at TMIT is that we will measure our success by how we protect and enrich the lives of families, patients, and caregivers. And today is really to focus on caregivers. Our mission is to accelerate performance solutions that save lives, save money, and create value in the communities and ventures we undertake. Our disclosure statement is on slide 9. There are no products, services, or technologies that will be addressed by any of the speakers today, but you can read the full disclosures. And our speakers and reactors on slide 10, I'll introduce each one of them with their bios, but we have Rob Cramer from an association of emergency medicine nurses. We have Chief Bill Adcox from MD Anderson Cancer Center, #1 cancer center in the world, with Assistant Chief Vicki King, and they'll be speaking together. We have Dan Ford, our patient advocate and voice of the patient. And now I'll move to Dan and ask Dan to really set our compass. Dan is a terrific patient safety advocate. When you hear about the HACs, the hospital-acquired conditions, and the update in my covering of the news, the very small group of patient advocates worked together to submit supporting documentation for the HACs years ago, and we were told by a leader at CMS that had that not been undertaken by this grassroots approach, they would never have gotten through. And so this is really a celebration day of some of the great work that Dan and the other patient advocates who you frequently hear with the patient voice address. As you all know, Dan has been in healthcare for many years. He's a retired search consultant, but he's also a veteran of the Vietnam War, and he was a navigator during that period. And I think he'll help us navigate through this webinar today and also be a reactor. Dan is a multi-published author in patient safety and routinely meets with a group of leading patient advocates in patient safety and serves in his local hospital systems as well. He's also known for championing the cause of including patients and families in root cause analysis. Dan, can you give us a few seconds of guidance today and set our compass?
Appreciate it, Chuck. You're very kind. I'd like to welcome everybody that's online today, participants, the audience, as well as our faculty. This is a very, very important subject impacting patient safety directly or indirectly in a whole bunch of ways. It's a subject that's unfortunate, it is reality, and it's complex. It's not only the physical violence, but bullying and other human behavior as well. One recommendation I have, and I'm going to make this early, and I can talk about this just a little bit later, is to include the voice of the patient in your planning and your RCAs. And I'll talk more later about that, both in patient family advisory councils as well as process improvement events. Last comment is, unfortunately, this mirrors some of the attitudes and behavior going on in our society as a whole. Thank you, Chuck.
Thanks, Dan. And so what I'll do is I'm going to take the next 10 minutes or less to go through a number of slides, and the purpose to do that is to give you a news update. Many of our audience are patient safety advocates and leaders who are updating their own teams. So I won't go through the content in detail because we have some world-class speakers, but I just want to make sure that you know that you have these assets available. As recently as last night, CNN put out a report that the FBI investigations in Midair sexual assaults has increased by 66% between 2014 and 2017. It came out on the news feed from CNN last night, and among those that it responded to a survey, 1 out of 5 of the flight attendants received reports of this, and this is a really alarming number, and the special agent in charge said that they are seeing this at an alarming rate, so we definitely have some societal things going on. Now, let's shift gears very quickly to the hacks. I'm going to go through a series of slides very quickly. For our patient safety leaders, you could use these to brief your teams on the impact of the hacks, the hospital-acquired conditions. $2.9 billion saved, preventing 8,000 deaths from 2014 to 2016. What a celebration. We thought that the infographic that Art provided was great for you. This one is on slide 15, and it allows you, I think, as an introductory slide to address them. Again, I'm not going to address them today. Great slides that you can use to brief your teams, and congratulations to those that have been able to cause these major reductions. CAUTI and pressure ulcers are the only ones that went up, and the rest went down. So we just want to make sure that you can download from ARC Kyle, please put the full document on the landing page for this webinar so folks can download everything. We put these slides together for you that address this dramatic drop by 17%. It's enormous, the number of patients that have been impacted by coupling payments and penalties. And many folks were saying, oh, gosh, it's so unfair to penalize the hospitals and it won't work. Well, the tying financial incentives did. So on slide 17, some of the engagement of patient safeties and families are there, Dan, and so I remind people to go back to that slide. On slide 18, they address the savings since and the estimates by 2019. And the estimates are $19 billion in savings, 53,000 fewer deaths from 2015 to 2019. So this is a gift that keeps giving. So Dan, thank you and all the patient advocates that worked with us on getting the hacks across the goal line. Just amazing. Slide number 19 also addresses in detail the baseline rate 2014 compared to 2019 estimated. So again, that rapid-fire set of slides is not for today. It's for you and your teams, those of you in patient safety. Now, you all know that we've been working on this MedTac program, which is the pre-hospital bystander care program, addressing 8 areas. The last area, and major areas like sudden cardiac arrest and choking and opioid overdose and major trauma and bleeding and the Stop the Bleed program. But the last one is bullying, and we are addressing full-on aside what's happening in our schools, but also what's happening in our healthcare institutions. So this is very timely. But this issue of opioid overdose, we've got to keep this foremost in mind with our leaders. This week in Bill Adcox and Vicki King's hometown, a Rice football player, Rice, great university. This was a great kid. But pushers had put carfentanil, which is used for elephants and rhinos. They cut it in drugs that they were sold, and this poor 21-year-old died of this accidental overdose. So this is happening in all communities. We saw it in Hawaii this summer. We see it in Orange County where I live. And so the next set of slides are, again, to help you bring this foremost to mind. We won't cover them, but this is the CDC report we've covered in prior webinars, and we'll keep digging down. Adults aged 25 to 54 actually had the highest rates of drug overdose deaths, and the synthetics are terrible. On slide 24, again, this gives you an opportunity to kind of review them with your team in the states that are the issue. The key slide is slide 25. Look at the climb rate of the synthetic opioids, fentanyl, carfentanil, and its analogs. This is a critical issue, and a lot of labs in China are sending them over here. These are being cut by people that really don't understand the volumes, and really causing an enormous problem. So that's in the news. Now, my second job today is just to review what we covered last month and report back to you your findings, the survey results, when we had a webinar on drug shortages, which was another critical patient safety issue. Our great partner, Greg Boats from MD Anderson, and a leading pharmacy specialist from Anderson covered this topic. And we also had the pharmacist from CHOC, the Children's Hospital of Orange County, who helped us find the last chemo dose for a young lady named Brooke Bezikoff, and we're able to get that last dose. Good news is she's in complete remission. The bad news is if we would not have been able to find that pharmacist to help us at one of our major California hospitals, she would have had to have a different chemo agent, and it would have threatened her remission. We asked the question, do you want additional information on drug shortages? And we had kind of an intermediate for us response. 77% agreed. 38% of you said we really want it. We will cover it again in the months to come. That's enough of us to know that you want us to cover it. Slide 30, which I won't read, covers the issues of drug shortages. We also asked whether you wanted more information on medication errors and adverse drug events. Now, that was a big number, with 49% giving us a 10 and 27% giving us strongly agree. We will, in the next 3 to 4 months, cover an update on medication errors and adverse events, the topics you covered on slide 32. And then now we're diving into this area of the abuse of power and workplace violence, which includes improperly treating employees, which may not be physical abuse, but it may be the abuse of power over an employee or making an employee the bad apple after a patient safety accident. And we've launched a program called the Healthcare Innocence Project, very similar to where DNA has been used to help people reverse decisions. We're using the electronic record. So just wanted to reintroduce that. Now, let's look at how much violence we have in America. This, on May 21st, just in the last month, addressed how much more frequently we have school shootings, 57 times the major industrialized nations. The same report by CNN, which you can use as an introduction, addressed where those locations were and what states and how frequently that they're occurring. On slide 36 is a detailed list, which I won't read, but again, this gives you kind of a chance to kind of address this, and a full article in the Washington Post about the Texas school that had a shooting plan, armed officers in practice, and still had 10 people pass away. So this is a critical issue. So now to introduce our speakers today. Serious workplace violence is on average 4 times more common in healthcare than in other private industries. Over the next 2 or 3 slides, we give you some examples that are in the press that you can pull when you give the talks in your organizations regarding things that have happened. I think storytelling is absolutely critical, and legitimate news sources that are covering them and that cite the GAO report on workplace violence are absolutely key. So over these last 2 or 3 slides, these are slides you can use to address, to set the issue up. Our audience today is probably pretty knowledgeable, so the goal again is to show these slides to let you know what you have, and the fact that now we're starting to put some great attention on this issue of physical, verbal, social workplace violence. the most important document, and Rob Cramer, who will speak on behalf of the emergency nurses, will give us some other important documents, but one of the really important documents is the Gao Report that actually cited the frequency and actually pulled the curtain back on this in March 2016. Get the report, read the executive summary. It will help you tremendously. Now, what is really critical for all of us are Sentinel event alerts and the Joint Commission, because 70 to 80% of our hospitals are certified by them. Sentinel Event 59 addresses physical and verbal violence against healthcare workers, and this set of slides should help you, and we recommend you download the infographic, which we will post on the website, and we've made slides for you that you can use that actually have a pretty good description. Now, what's really important, take a look at the text box at the bottom of this slide. The U.S. Department of Labor defines workplace violence as an action, verbal, written, or physical aggression, which is intended to control or cause, or is capable of causing death, serious bodily injury to oneself or others, or damage to property. The misuse of an HR department after an adverse event that can happen to one of your patients, the misuse of the processes within an organization fits within this Sentinel event. So it isn't just physical, it isn't just emotional, it isn't just verbal, but it's also the misuse of power intended. It's an aggressive behavior which can cause harm in the organization. And we know that over 60% of our employees are afraid that if they report a patient safety event, that it will go in their employment record. And if it does go in the employment record, we have ample evidence to show that there's an epidemic of the misuse of HR departments. I will not go through the detail of the next few slides because I want to shift over to Rob Kramer and have him frame the issue, and then Chief Adcox and Assistant Chief King. But this graphic that you see, 75% of nearly 25,000 workplace assaults reported annually occurred in healthcare. The numbers are here, and they're with the Joint Commission. So if anyone in your organization wants to challenge the numbers, no one will challenge the Joint Commission because they're reviewing you, and this is a Sentinel event for most of the organizations represented today. Each episode of violence or credible threat to healthcare workers warrants notification to leadership. This happens rarely, really critical. It is a Sentinel event that should be reported. So finally, the actions that are suggested by the Joint Commission in Sentinel Event 59 are, number one, clearly define workplace violence. It has to include the intimidation of employees, especially after a patient safety event, recognizing that data come from several sources, capture, track, and trend it. Provide appropriate follow-up and support to victims, witnesses, and others affected. We always talk about the second victim. There are those that observe what happens. We really need to make sure that they feel fitness for work as well. Number four is review each case of workplace violence to determine contributing factors. Develop quality improvement initiatives, train all the staff, and evaluate workplace violence reduction initiatives. I'm sure Rob is going to address it's just profound how much physical and verbal abuse occurs in our emergency rooms. Absolutely critical. And we know that our emergency medicine caregivers are kind of the tip of the spear when the folks are coming into the hospital. And so a number of the activities that or issues on slide 48 are critical. Again, these are all in the Sentinel event literature, which we're posting for you. Now, the next slide is weaponizing HR after an accident. We are seeing an epidemic of leadership using the HR department to define the bad apple. If a patient safety accident occurs or physical abuse is reported in the emergency department and the leadership doesn't really want to address it, they can actually impugn the integrity of the caregiver, of the nurse or nurse student. We're working with a number of them right now. The question is it the barrel, meaning the systems and policies, that are the problem, or the bad apple that has gone bad? Cynthia Shapiro, who wrote Corporate Confidential, who I talked to yesterday, will be our speaker, one of our speakers in August, will address the weaponization of HR after an accident and her experience, she is one of the world's leaders in this issue. And the goal is to focus on, well, what are the best practices that we can use to make sure that we don't blame the nurse, the ED nurse, that actually has something happen to her to protect the organization, and he or she, the nurse or the doctor, and this truly is an insider threat. So it's really a great pleasure to have Rob Kramer now kind of frame the issue for us with emergency medicine nurses. Rob is the Director of Government Relations for the Emergency Nurses Association, where he works to develop and execute their government relations strategies. He's recently helped lead an advocacy program that resulted in enactment of one of their top legislative priorities, and we'll ask him to describe that. It earned the Gold Circle Award for Advocacy in 2017 from the American Society of Association Executives. He focuses on these issues. He focuses on workplace violence, trauma care, and the opioid epidemic. And prior to joining that organization, he had positions with large patient advocacy organizations on Capitol Hill. So he has a bachelor's degree in criminology and a master's degree in public administration. Rob, thank you so much for framing this issue and helping put the attention on the emergency medicine focus area.
Well, thank you, Chuck, for introducing me, and thank you, everybody, for joining. Like Chuck said, my name is Rob Kramer. I'm the Director of Government Relations for the Emergency Nurses Association, or ENA. I am based out of Washington, D.C., and I come at this whole problem from a little bit of a different perspective than many of you might, more from a public policy and advocacy perspective rather than a clinical one. But what I've been able to do over the past 2.5 years while I've been at ENA is really internalize the experiences of our members. And when I go to the Hill to talk about these issues, and I can really kind of relay to them what my members are going through and what many healthcare workers around the country are going through on a daily basis. So the first thing I want to do very quickly is just give you a quick outline of what I want to talk about. So Chuck's done a great job of sort of beginning to frame the issue about why healthcare workplace violence in the United States is such a large problem. And I'm going to go over some of the statistics revolving around that and sort of build out why nationally and globally across healthcare this is a huge problem. I'm then going to talk to you a little bit about why emergency departments and the people that work there are a little bit different in terms of their susceptibility to this violence. What you'll find is that EDs, being the front forward-facing part of a hospital, are often the sort of epicenters for violent events within a facility. Next, I'm going to go over the impact that all this violence has specifically on emergency nurses in terms of how it makes them feel on the job, stress, turnover, things like that. And then I'm going to kind of launch into what we at ENA are currently doing both at the state and federal level in order to, hopefully fix some of these problems that are going on out there. So the first thing I want to do is sort of frame the issue nationally, and I want to do that through the use of some statistics that we have. And although the data that you'll find by reading the reports that are out there, the data is inconsistent, it's sometimes unreliable, but it is out there, and it does paint the picture that healthcare workplace violence or workplace violence in the healthcare sector is a national epidemic. It is a huge problem, and it's only getting worse. So the Government Accountability Office back in 2016 published a report that cited that workplace violence was a, quote, serious concern for the nation's healthcare workers. They estimated back in 2011 that there were between 22,000 and 81,000 incidents of workplace violence in healthcare facilities across the country. 22,000 to 81,000, that's a huge range that doesn't really give us a good sense of exactly how many violent events are occurring in healthcare facilities, but what it does give us a great sense of is the lack of reliable data that's out there, and we'll touch on that in just a little bit. But it is a huge problem. There are thousands of these incidences that go unreported each year, and millions of healthcare workers are affected by violence in the workplace. OSHA, the Occupational Safety and Health Administration, as I'm sure many of you are aware of, back in 2015 published another report that cited that between 2002 and 2013, workplace violence against people that work in the healthcare sector was 4 times greater than violence against those who do not work in healthcare. And the one statistic that was in that report that I use a lot on the Hill that I find to be particularly impactful is that what they found in this study was that back in 2015, that although healthcare workers only make up about 20% of all patients regarding workplace injuries, they do comprise about 50% of all victims of workplace assault, and that is across the board, across the country. So, what this does is it really kind of helps to paint the picture that workplace violence in the healthcare sector and against healthcare workers is a giant problem in the United States that has to be addressed immediately if we're going to stabilize the workforce in that sector and stabilize care for our patients in that sector. The next thing I wanted to talk about is a little bit about why the particular characteristics of the emergency department make it a more susceptible place for violence. And I'm going to do that, we'll kind of talk about what characteristics are out there. So the first thing that sort of sets emergency departments apart from the rest of the hospital is that they're 24/7 operations. Now, while the inpatient and the rest of the hospital are 24/7 operations, they're not necessarily accepting people from the public or accepting visitors from the public 24 hours a day, 7 days a week, like EDs are. And so they're open 24 hours a day, 7 days a week. And we're not necessarily talking about violent events that are occurring at, 12:30 p.m. after lunch on a Tuesday. What we're really talking about is the day in, day out overnight shifts, the weekends when things kind of get, can be at their most unpredictable. Internal laws are also something that set EDs apart. Anybody that walks through the door, as you know, of an emergency department of a hospital has to be screened by the ED. And if they present with a medical emergency, they have to be stabilized or transferred if they're in need of care. So that is sort of an element that requires emergency departments to not turn anybody away. They cannot, assess people for their ability to pay. As you know, they cannot assess people for their ability to have insurance. So they're required to take all comers. Another thing that is present in the ED is that emotions are running very high. Circumstances are often very unpredictable. You have, in the emergency department, you encounter people from all walks of your society. People are there for different reasons. Many people are there experiencing the worst moment of their lives. Many people are there experiencing the worst moment of one of their family members' lives. And so you have this sort of emotional powder keg that presents itself within the emergency department, not only amongst the patients, but also among those who are joining in there in support. And then, finally, another issue that I'm sure many of you are aware of is the boarding of patients as an ongoing problem in the emergency department. When there are staffing issues throughout the hospital in the inpatient sector, if inpatient beds are unavailable or if the staffing levels, for that hospital are below what they need to be for the number of patients, oftentimes what happens is, of course, patients get boarded in the emergency department until space or staff become available within the inpatient sector. This, coupled with the high problems associated with mental health care boarding in the emergency department, really kind of create a volatile powder keg of situations where you have a high number of people, emotions are running very high, and things in circumstances are very unpredictable. And so what that leads to is an explosion of violence in the ED that you really don't see in other sectors of the healthcare industry. So the American Journal of Emergency Medicine back in 2013 published, let me back up there. One of the slides that Chuck had put up earlier was citing a statistic from the American Nurses Association that reported that 1 in 4 nurses, and this is nurses across the board, had reported they had been assaulted at work. That's about 25%. Across the board, all nurses had reported that they had been assaulted. Studies that we have about emergency nurses revealed that there was 2 studies that were done, one in 2002, one in 2004, and what they combined sort of came to discover was that within the past year, so this is around the 2003 span of time, 100% of emergency nurses and emergency department personnel had reported verbal assaults against themselves, and 82% had reported physical assault against themselves. So we're looking at a statistic comparison where we're talking about 25% of nurses over their career have been assaulted, versus 82% in the past year in the emergency department had been assaulted. And so what you see is a much higher level of violence in people that work in the emergency department. What AGEN found was that they experienced violent events about once every couple of months or about 6 times per year. That is either them witnessing a violent event or one occurring against them. As a result, what you see is that workers in the RNs in the registered nurses in the emergency department have much higher levels of acute stress and the associated health concerns as a result. So the impact on emergency nurses is actually quite high. It affects them very negatively. As we talked about just now, emergency nurses report higher rates of acute stress. There are also studies that show that 94% of emergency nurses report symptoms of PTSD, and 17% of those are probable for a diagnosis of PTSD. And so these are conditions that normally we see soldiers coming back from the battlefield with these types of symptoms and with this condition. And these are our nurses in our hospitals that are reporting symptoms of PTSD from the level of violence, the frequency of violence that they experience on the job. And what this leads to is a situation where emergency nurses have higher sick days, they have more workplace injuries, they have higher rates of workplace illness, and ultimately higher turnover. And what we found at ENA was that about 1/3 of ENs who were surveyed had considered quitting the profession altogether. And I'm talking about nursing, not just emergency nursing, but nursing altogether as a result of the level of violence that they see at their facility. Making matters worse, as Chuck alluded to, is that there are many institutional barriers that nurses encounter when they are assaulted. The top of mind may be that they feel that they're not supported by their employers. There are many hospitals out there that are, that we hear anecdotally that are more concerned about potential quality scores and survey scores from patients, and they don't want to necessarily report the violence in order to, keep the reputation of their hospital high. Getting these reports brings down the reputation and it makes the hospital look bad. At least that's what our members are telling us. And many hospitals don't have consistent, policies in place about reporting levels of violence. Another thing that can really interfere with this is that you see an inconsistent response from law enforcement, and this often occurs, of course, at the local level, where you have prosecutors that are looking at, that are dealing with large-scale problems like prison overcrowding, jail overcrowding at the local level, and they don't want to arrest people in the hospital for assaults when these incidences do occur. You have law enforcement officers who are reluctant to arrest, or they cannot arrest for this type of assault unless they witness the assault themselves, or unless they find injury that would lead to probable cause for an arrest. And so you see an inconsistent response not only from your boots on the ground law enforcement police officers that show up at the facility when a violent event is reported, but also down the line from prosecutors who don't want to try these cases. One other thing that I'm sure everyone on this call is aware of is the culture of acceptance of violence that seems to be sort of institutional and systemic across the country within our nation's hospitals. Many nurses, as they sort of grow within the nursing profession, learn and become sort of desensitized to the violence that they're experiencing, and they're told that it's a part of the job, or they come to accept it as a part of the job when it absolutely should not be. And then one more thing is that it's very difficult right now with the data that we have, or what shall I say, don't have, to track the trends that are going around the country regarding the violence, as well as collecting the data itself. There are very few requirements out there, in terms of state laws that require hospitals to collect this type of information. And so, what are we doing about it? At ENA, of course, I'm on the government relations side of things, and so my job, part of it is to, put together strategies and seek out opportunities for us to not only raise awareness about workplace violence around the country, but also to enact policies or legislation that can do something about it. So we sort of have a two-pronged approach, as you might imagine. We have efforts at the state level to not only raise awareness, we do this through letter writing campaigns. Our State councils at ENA hold community events where they, will educate the public about rising levels of violence at the facility. Because I think the public is very unaware of the level of violence and the frequency that not only nurses in the ED but also healthcare workers writ large are experiencing across the country. Mainly what we've done over the past, I would say, decade or so is really fight for tougher penalties for workplace violence against emergency nurses specifically, but also for a larger, broader population of healthcare workers in general. What we have generally sought is for states to make assault against an emergency nurse an automatic felony or punishable through felony penalties. 31 states have done this already. We're still working on the other 19. And what we're really trying to do is put assault laws that exist out there already that protect professions like police, fire, EMTs, public servants, and really put those laws to work for people who are facing very, very, very high levels of violence and often don't have any training or the wherewithal to be able to deal with it as it's occurring. So trying to bring parity to the laws to protect nurses and other healthcare workers is one of our goals. And then beyond that, of course, there are a number of states that have passed laws that require their hospitals to not only report incidences of violence, but also develop and implement workplace violence prevention plans that take into account and receive feedback and buy-in from their boots on the ground employees, including emergency nurses. So, for example, in the past couple of months, we've seen South Dakota actually pass a law that makes it a felony to assault emergency nurses. That brings in line their laws with state protection for police, fire, and EMTs. And then in Alaska, they actually just passed a law, and I think Governor Walker, we're currently about a week left for him to sign the legislation before it becomes law, but it would require hospitals in Alaska to implement workplace violence prevention plans. And then at the federal level, there was a meeting many of you may be aware of back in late 2016, with the Occupational Safety and Health Administration regarding workplace violence and the possibility for them to enact a national standard for workplace violence in the healthcare sector as well as social work. They held that meeting. We attended. A number of our members from Virginia, D.C., Maryland, Pennsylvania. I think we had maybe one from Delaware as well. Came and provided public comment during that meeting. And so we're continuing to try to work to push forward the sort of unilateral regulatory push from OSHA to implement that standard. But then there's also new legislation that was mentioned in one, or at least the sponsor was mentioned in one of the slides that Chuck had put up there. It's H.R. 5223. It's the Healthcare Workplace Violence Prevention Act. And what this would do is basically it takes what OSHA was seeking comments on back in 2016 and puts it into legislation in order to compel OSHA to act should Congress pass the bill and should the President sign it into law. And so that would require hospitals who are under HHS's authority, more or less, mainly those inpatient facilities and emergency departments that accept Medicare and Medicaid, to develop and implement workplace violence prevention plans. And I will tell you that we've been working quite closely with Representative Khanna from California, who's a sponsor of this legislation, and I do know that their efforts at the federal level are mirroring efforts that were done at the state level in California on a law that was passed a couple of years ago that pretty much does the same thing. It requires through Cal OSHA for hospitals to implement workplace violence prevention plans. So there's a number of different things going on currently, at the state level and the federal level to, shore up the laws against workplace violence, to implement programs that provide nurses and other healthcare workers with additional training, with mitigation strategies, and with priorities and policies that are put in place that really support nurses and employees when they are assaulted on the job. And then finally, I want to tell you a little bit about some of the ENA resources that are out there on our website, ena.org. We have, of course, talking points about workplace violence as well as our position statement. We at ENA favor evidence-based approaches on prevention, as well as implementing zero-tolerance policies for facilities when violent events occur. We also offer continuing nursing education modules that are available to our members online that help them recognize and mitigate violence. And this was developed in conjunction with the American Organization of Nurse Executives, or A1, and it includes the principles that we developed together with them. Also, we have an ENA toolkit that's available online. It is not necessarily behind the member wall. It's publicly available. It is a department-level focus, mainly towards nurse managers, and it's really targeted for them to implement with their staff. But it really kind of targets mitigating violence, protecting staff from violence, implementing policies that encourage employees to report violence when it does occur. That toolkit is currently being updated, and I've been told to let you know that they're adding Type 3 and Type 4 violence to the training that's in the toolkit. Type 3 violence includes relationship violence as well as bullying, which I know is a focus of one of Chuck's slides earlier. And then Type 4 violence is, of course, organizational violence. And I think, Chuck kind of touched on this as well. And organizational violence in this aspect is when the facility doesn't fully address or fails to address the ongoing problem of workplace violence that they have at their facility. So at ENA, we are doing a lot of work not only on the policy side, but also on the educational side to raise awareness about workplace violence, provide tools for emergency department managers to implement in their own facilities and hopefully protect workers. But we're also working to bring penalties in line so that when assaults do occur, because we're never going to be able to prevent 100% of these, that there are appropriate penalties and that there's appropriate punishment that is out there for people who do assault healthcare workers while they're on the job. Because ultimately, what emergency nurses and what all of you and your staff are providing are critical services to the community that the community would not be able to function without these services. And we don't need these high levels of turnover. We don't need these high levels of workplace injury, workplace illness, and things like that. We don't need our nurses to be in a constant state of sort of heightened alertness, or as it would come with PTSD. So thank you, everybody, for joining us. I'd be happy to kick it back over to Chuck or answer any questions if you wanted to open it up for that. But thanks, Chuck.
Great, really wonderful briefing. What we'll do, Rob, is give the audience an opportunity to put their questions in electronically after Chief Adcox and Assistant Chief King give their talk, and then we can address them after we give each one of you an opportunity to comment on each other. Thank you very much. Excellent presentation, and you just illustrate how critically important and what a tip of the spear the emergency medicine nurses are. Just as an aside, I talked to someone that monitors the bullying hotlines across the country. 50% of the calls into bully hotlines are nurses. That's across the United States. It's amazing. And that's not healthcare. So really pretty amazing. Thank you so much, Rob, and congratulations on the great work you're doing. So Chief Bill Adcox and Vicki King will take, now they're going to help us, Rob, really dig into what we can do and get what we would call left of boom into not only addressing the workplace violence, but actually prevention. And I think that they're leaders in the world in threat safety science in this area. So it's pretty exciting to see them address prevention, preparedness, protection, and performance improvement, the 4 Ps. Chief Adcox holds an MBA from UTEP, and he is the Chief of Police for UT and the whole Health Science Center in Houston, representing, I believe, Chief and caring for over 20,000 people. And Vicki King has also had an esteemed career as now Assistant Chief. And together, not only are they doing a great job protecting the folks at MD Anderson, but also addressing insider threats, outside threats, and all-cause threats. And they're being invited to actually chair an international summit with the WHO in 2019, which we'll share more about. So both have been highly recognized for their great work, and they have been partners in, and the chief has been a lead partner in the MedTech program and has actually led the law enforcement officer and security program along with Dr. Greg Boats on teaching the MedTAC program to law enforcement, which is much more sophisticated than the bystander care programs. And it's such an honor to have them address the workplace violence today and their perspective from the world's leading cancer center. Chief, please take it away.
Well, thank you very much, Dr. Denham, and thank you to everyone on the call and part of the webinar. I think that Dr. Denham did a great job introducing the Joint Commission's Sentinel event number 59. I would encourage everybody to read that, and there's lots of resources that are attached to that, as well as Mr. Kramer did a wonderful job in zeroing in on the challenges that we have in the emergency departments. We'd like today just basically cover a little bit more about the complexities in healthcare, and then talk about mitigation, particularly around the 4 Ps, as Dr. Denham said. First off, when we talk about the complexities, a few things that come to mind is, when we think about healthcare setting, we talk about the open environment, how welcoming we are, how all walks of life come through the front door and they come to us for help and care. We look at leadership commitment in our environment. Healthcare is very, very care-oriented in terms of practices and clinics, and basically you look at it mainly as a bunch of silos. And we give a lot of deference and authority to the different pieces and levels of leadership. So when you think about leadership commitment across the board, from the CEO all the way down, it is truly a challenge. The culture, I think Mr. Kramer talked a little bit about the culture, particularly as it pertains to the nurses, but our culture is one of being very caring, being very welcoming, and with that leads to often to the underreporting of workplace violence issues, including bullying. And what that really does is it doesn't allow us to have a full picture. It doesn't allow us to do the analysis, look at what are the gaps and what are the root causes and what's going on, so that we could have prevention mechanisms in place. And so it is a very tough issue to deal with. And the last thing is that there's many types of violence, and we're going to go ahead and talk about the different typologies here today. And with each comes a different way of measuring, a different way of assessing, and a different way of approaching and preventing them. And so these are just some of the real complexities. The other thing is the high stress environment that we work under, as well as how vulnerable the population is. So we've taken a minute here to put up some information about our institution to talk about what we're talking about in this arena. So when you think about the vulnerable population, so for us, we have a very large vulnerable population, and you can see it up there as far as the encounters with the patients that are 65 and older, as well as the encounters we have with the younger patients. So these are really some truly vulnerable population sets for our community. Also, there's some compromised perception and judgment that we see in our setting. I won't go through all the details there, but you can see the different things, including some of the prescriptions that I've put up there specifically so that you can see. But one of the things that I think is most notable for us is that when we were talking to one of our patients simply stated that he's a concealed handgun carry licensed individual, but that he knows what happens, and he locks his gun away while he's undergoing his chemotherapy sessions, and that to us was very, very telling. I'm going to go ahead and Vicki?
Yeah, one of the things we like to do is we need to classify our workplace violence, and we do that using the typologies that were established by OSHA so that we can compare ourselves to other industries. You can see the typologies that are recognized, type 1 through 4, the no affiliation. Type 2 is a customer, a client, a patient, someone who has a relationship with the institution. Type 3 are the worker-on-worker type of events. And then type 4 are the personal relationships that have an impact on workplace violence. Our institution tracks one other, a type 5 workplace violence, which is self-harm. Self-harm does have an impact. If there's a suicidal ideation by a particular individual, that's handled differently. We also know in our care environments that self-harm can also lead to the murder-suicide, especially when you have a mercy-killing type of event and the person who believes that they are doing right by fast-tracking end of life for an individual and then chooses to harm themselves. So when we look at these in terms of trying to mitigate the events, and one of the things that just resonates is an incredible statistic is in 2015, it's already been referenced, 75% of the 25,000 workplace assaults reported occurred in either a healthcare or social service setting. So we're going to go through some of these typologies real quickly and give you some case studies and talk about how the threat mitigation, the threat safety science differs from a traditional approach. This case was one that happened on our campus. A habitual offender was burglarizing some offices, and one of our faculty members confronted him and asked him what he was doing. He said he was there looking for someone, and when she reached the call for the police, he attacked. The interesting thing about this particular offender, he was arrested, but he didn't flee the area. He went from our med school over into the main hospital and began to continue with his trek to try and harvest anything of value from patients, faculty, staff. And he was caught inside the main hospital. This is a typical kind of threat scenario where most institutions respond with guns, gates, and guards. The target hardening, the increased visual presence of security. But when you start to look at the root cause, there are some human factors, some better threat indicators that you can analyze to get a better result. And in this particular case, not only did we look at the victim, and she was an extremely brave soul. Thank God she wasn't injured more than she was. And we talked about her approach and some of the things that she could have done a little bit differently, not to victim blame, but to give her a different safety plan. We also did some education with the team, with her work group, and in fact, we did institute some target hardening approaches. But the biggest thing, and the part that seems to be missed most of the time by law enforcement, is they go in, they make the arrest of the offender, they book them in jail, and they move on to their next case. In this particular case, we went and began to drill down on this offender to better understand why he picked us and what our vulnerabilities were in that event. We did jailhouse interviews. We found out that, hey, we were an easy target and found out what his ports of entry. We also found out some interesting things about him. He had 12 arrests in the state of Texas and 9 arrests in the state of Arkansas. We began to build a case as a habitual offender who, when he goes out and he gets out of jail, the only thing he knows how to do is to reoffend and to come back to the same places. So we began a program, a safety program that involved him, and that is to monitor his case through the criminal justice system. If we had a plan in place in case he was released on bond, ankle monitoring, and even active surveillance of him if required. He did not get released. We made an enhanced case to keep him incarcerated for as long as possible, and we plan on parole board engagement with him. It's just a different approach to do more work after the arrest than just simply arrest and move on. This was an interesting case, and we look at our cases and that we handle, and our stats seem to stack up that 93% of all assaults against healthcare workers come in the typology of customer-patient. This is an extremely vulnerable population when you have family members. This is a highly stressful event. In this particular case, this happened here in Houston. Emergency room patient wasn't being attended to in the timeliness that he thought was appropriate. He took out a gun to get attention, and when people reacted, he fired a shot. he was ultimately confronted by a sheriff's deputy who exchanged gunfire with him. So, one of the things we look for and we have done immense training with our team, our care teams, our triage team, our security team on de-escalation techniques. He was angry. He had expressed his anger long before he took the violent action. So we want to teach them on how to recognize behaviors of concern. We want to teach them how to talk. And if they're not getting traction with the patient or a family member, to engage the security team, the law enforcement team early. One of the things we want to do is make sure that they're being heard. We also look at patients and visitors who have negative encounters with our faculty and staff, and we track those. We look at forward-facing appointments. We look at what were the triggers. We look at and try and analyze how we can mitigate the issues that occurred in past visits. We also look at outside stressors associated with those individuals that may be impacting their engagement with our faculty and staff. We have a behavioral intervention team that helps us. This is not the police department doing this unilaterally. It is truly a multidisciplinary approach to the event. So we work together to develop mitigation strategies. The worker on worker, there are many types of examples that we could bring, but this one was probably one of the most recent and devastating examples that occurred in New York City. In this particular case, many of you are probably familiar with it. This doctor had been terminated from the hospital, and the hospital, he had many problematic behaviors leading up to this, many different behaviors of concern, and the misnomer is that once you terminate their employment with your institution, that the problem is also terminated. We disagree with that, and we ask that we be engaged on any kind of contentious termination process that we be brought in before that process occurs, that our behavioral intervention team can look at the facts and circumstances surrounding the employment, outside stressors, outside criminal activity, social media posts. We help develop a separation plan that provides a term that we've coined a soft landing. Can we do some face-saving things up front that can help this person separate with dignity and respect to minimize their animosity towards an individual or the institution? And we also have a post-termination plan, which includes monitoring social media, open source information, looking for leakage, and helping to see if the person is successful as they move on. The interpersonal relationships, we all know that the most dangerous time is when a person breaks up from an abusive, intimate partner. This was a love triangle, this particular case, and some of the things that we like to do, we're not trying to get into people's personal lives, but when there are behaviors of concern that are exhibited, threats that are made, stalking behaviors, those are the things that we like to be engaged in early so that we can develop safety plans and intervention strategies. We look at, many times we have seen that in a domestic violence situation where the offender is arrested, that the violent behavior actually escalates post-arrest. So we have a post-arrest process that we institute so that we can monitor. We monitor jail contacts and jail phone calls. We do post-arrest threat monitoring, contacts. We may ask the court for ankle monitoring and other things that would be a part of our safety plan to help mitigate the risk. And then finally, our self-harm category. This was a particularly tragic case that occurred where a young patient's mom took her 5-year-old child's life after an approximate 1-week stay in the hospital. Some of the information that the hospital didn't have, which may have played a role in their safety planning for this particular child and his mom, was the fact that the mother feared that she was going to lose custody of the child. And there have been multiple referrals, and anytime anyone at the hospital questioned the care of the child, then she began to see it as a reality that she was going to lose this custody. So one of the things we want to do is we want to break down those silos of information, gain as much information, not just about the care of the child while they're an inpatient, but more importantly, what's the environment outside the hospital and what are the stress factors on his caregivers or people with access to him. So those are some of the things that we try and look at to prevent these kinds of events.
So let's take a look at the 4 Ps. So one of the things that I like to stress is the most important piece for protecting patients is our caregivers. So you want to make sure that we're taking care of the patient, we're asking the right questions, and that all of our caregivers are reporting any of the threats or suspicious activities they have. And I think that's the most critical piece in terms of what the caregivers can do. So we have primary prevention here. So we're talking about, I won't go through all of these, but what you want to do is you want to, in order to have your prevention efforts in place, you want to make sure that you're gaining your institutional support. You want to be able to create your business case. You want to establish your value propositions, and to provide the necessary performance measures that help the executives understand. You really need to look at establishing your threat and your risk protocols. Again, you see up there identifying your threats, making sure that you have a centralized reporting system so that it can be appropriately triaged by a cross-functional, multidisciplinary team. You want to assess that threat, and you want to allocate the necessary resources in order to mitigate it. And really important is, again, is this area, this arena that we're going to talk about, and that's educate and training your community. The other thing is that the Joint Commission actually requires written plans at every hospital, plans that's how you're going to provide security for your patients, your staff, and your visitors. But they also require you to determine what are the potential areas of violence through your assessments. So what you want to do is you want to make sure that you have the necessary professionals in place that are going to conduct these risk and threat assessments so that you can, and in our case here, this is just an example of a heat map that talks about what are the areas that are being properly protected and what are the areas that need the most work. So again, you need to make sure that you're completing these risk assessments and putting that in place in order to protect things. This here is what we call the Crisis Continuum, and I think this is really important for everybody because it brings about a couple of very important points. Number one is, if we're not reporting suspicious behavior, if we're not doing what we should do in that area, we have this tremendous information gap, and quite frankly, that's what's going to lead to a catastrophic outcome. If we have the information and we're being triaged and we're being able to look at it properly, we can then have intervention strategies that are going to bring it down to a positive outcome. The other thing is, and this is what I think can help a lot of you in your organizations, is if this is done properly, you're talking about a huge financial impact. Because if you can bring this situation down, you're not going to be investing tremendous amounts of resources and money, and even some, the reputation damage and other things will occur if a bad event occurs. So that's very, very important.
And as Bill said, you can't act on what you don't know. And so initial report will come in, and you may have very limited information. So we push that to a multidisciplinary team where we sit down once a week and we go over these threat cases, or in an emergency situation, we can come together very quickly. And each of us are gatekeepers for silos of information within our organization. There may be HIPAA concerns. There may be, in our university setting, there may be FERPA concerns. But we bring the information team together, and we start to share that information to mitigate the threat. And then together the team comes up with recommendations for how we're going to proceed, what safety plans and what the safety plan is going to look like. And we may even farm out to specific personnel, whether it's HR or our employee assistance program people or our threat management team, different tasks that they're going to come back, or different information gaps that need to be filled. and we come back together and work on a collaborative plan to mitigate the threat. And we do this in order to find the root cause of what's going on. We have to know the why behind what's happening if we're going to be effective. So, as Bill talked about, our preparedness plan is to train and educate. We do that in crisis intervention. We look at de-escalation, employee assistance, mental health awareness. We talk about behavioral interventions. We talk about the resources that our institution brings to bear, doctors, nurses, psychiatry. We have an integrated reporting system and a cross-functional intervention team because we want to get the best results. We don't necessarily want to put together a prosecution case where we're playing gotcha. We'd much rather prevent a bad event from ever occurring in the first place. So there are some responses, everything from how to properly restrain an individual to a worst-case scenario in case of an active shooter where we're going to do the run, hide, or fight scenario. So the next key is our preparedness. I mean, we talk about you're preparing a little bit when you're doing your training, but we're going to prepare people if the worst should occur. And I think MedTAC is probably the most comprehensive and the most effective means to gaining that. We have had our team members who take this training in-house and gone home and saved a life. They've saved a life on a football field. They've saved lives around swimming pools. They have saved lives in knowing how to do and how to control the situation and what to look for and how to prepare in case getting left of boom, in case something bad should happen. And then our protection team, you got to know how to respond. It's a layered approach, utilizing multiple systems, multiple designs. We have technology, we have people, and those people know what to do and how to respond and how to gain this integration of all these services. We are continually outreaching to our community. We have a lot of turnover in a university hospital setting, so we want everyone to be engaged. We want everyone not to just know the see something, say something mantra, but more importantly, what should you be looking for and to whom should you tell? And then we always incorporate the best practice standards from our Joint Commission partners and the various accreditation teams that help us get better at what we do.
So the last of the P's is performance improvement. And again, this is really important to everybody because when you're talking about workplace violence, you need to have continuous review, particularly every time there's a near miss or there's a near event, or every time that there's actually a problem or something was to occur. You've got to have a postmortem. You've got to have a review. You've got to look for continuous improvement. You've got to evaluate virtually everything that you do in order to identify gaps and in order to find the many areas for improvement. Again, you need to dismantle the silos of information, bring together your multidisciplinary team, and then be able to focus on what it is that you need to do. Also, we recommend that people have in place data visualization. So the reason that we recommend that is, at least for us, it helps us to establish appropriate measures, and then we're able to look at the proper metrics. We're able to put it up in an easy and explainable fashion so that the executives understand what we're doing and why we're doing what we're doing, so it brings a great deal of value. You think about it like here, this piece here with the threat management, we actually track when we have a threat comes in, we put together an intervention. Once we've applied it, we come back and reevaluate it to see if we've had the drop in the level of that threat. So that's an easy representation of a metrics that we have that everyone can adopt. So if I could just take a minute and kind of close up on what we were talking about, we approach this issue from a systems approach. We look at it through our 4 Ps, and we want to make sure that people understand that when you're dealing with workplace violence and you're looking at behaviors of concern, you're looking at target hardening, you're looking at everything that we can do in order to have a welcoming and a safe and an honorable place to work. We recommend that you always think of things in a systems approach and you do it through those 4 Ps with an eye across the performance improvement, so that you can ensure positive outcomes. And we certainly, on our side, wish everybody the best of luck, and they're available if anyone needs some help. And we went through this stuff pretty quick, but we are available to assist you if you have any questions. Chuck?
Thanks very much. Wow, 2 great presentations. And we're going to ask our audience now to answer some survey questions, because I know, for one, I would love to have more another session on workplace violence issues, this emergency medicine. Rob, if you can let us know organizations that have implemented a really good program and started from scratch, and Chief Adcox and Assistant Chief King, if you could perhaps put our heads together regarding a real practical approach on how an organization might build a plan. This is going to land at some point in the patient safety officer's lap, one way or the other. As John Nance, who emailed me during this presentation, always says, there's a lot more in the wheelhouse of safety officers than they realize, and these things are going to land there. And now that we know the numbers. So on the survey questions, Kyle, thank you for putting them up. Please give it a 10 if you want to have more, and if there are areas that you want to cover. And we're also going to come back to the questions here in just a minute. But the second question is, I'm interested in a webinar on an action plan after an adverse event, and it could even include one of these workplace violence events, but it's been long overdue that we revisit what are the action steps now that we need to take after we have a patient safety accident, and we'd like to know what you'd like to have covered on that. And then the third one is on HR practices. Do you want focus on the best HR practices after an adverse event, and what would you like to have covered? We think that we will likely present this in August of this year. For those that are viewing, we're likely going to do that. But I know that Rob Kramer has really made great time for us. I know he's got a critical commitment right after. So I'm going to go to him first as our reactor, just to react to what he heard from Chief Adcox and Assistant Chief King.
Well, thanks, Chuck, and thanks to the other presenters. I think it's really remarkable, the thoroughness that I'm seeing in terms of their approach to the facilities and what their reactions are and what their plans are in terms of trying to respond, especially to events when they do occur. And I've not seen presentations that sort of talked about a response or what particular institutions are doing about these problems, especially the problems that are coming in for, like sort of targeted events from the community rather than sort of random emotional acts of violence that occur because of situations within the facility. So I'm very impressed. I'd definitely like to learn more about that.
Fantastic. Let me go to Dan Ford. I know he had a computer drop off. Dan, are you still with us? I don't think he is. So Bill and Vicki, in order of Bill and Vicki of our speakers, do you kind of want to build on what you heard from Rob, specifically to the emergency department? I know that when we were filming at MD Anderson, Dan's there. Dan, do you want to kind of react to what you heard from our 3 wonderful speakers, and then I'll go to Bill.
Yeah. Sorry about my imperfect system, and your protection team helped me out. For all the phrase that I heard while I was waiting here. Curious, Rob, the new laws you talked about, in my opinion, are necessary. How much impact does that have, and will that have, at a moment in time when emotions are high? Kind of like, yes, they're really necessary, but the question is, at a moment in time when emotions are really high, anybody going to stop and think, well, hey, I probably shouldn't do that because I might get put in jail?
Dan, that's a great question, and honestly, I think the reality is, and this is my background in criminology from college is coming back to haunt me here, because you sort of have to admit to yourself that it's difficult to measure the negative impact on crime that a deterrent penalty within a criminal law would have. So if we up what Dan's talking about here is, if we up the penalty, how do we know that's necessarily registering in the mind of an offender in the moment in an emotional outbreak within an ED. And I agree that is a perfectly valid point. And how I would respond to that is while we cannot measure the deterrent effect, and I can't even speculate that it would have one. What I can tell you is that within the eyes of the law, bringing these penalties in line with other laws that protect other forward-facing professionals that also experience high levels of violence within their professions is something that is a message to the community that we're protecting these individuals. And I think bringing, you're protecting other populations for a particular reason. And it's because they're forward-facing to the public. They have to interact with the public. They don't have a choice. That's part of their job. And because of that, they experience high levels of violence. Emergency nurses and other healthcare workers do too. So you need to put them in the same category. And it's all about parity, and it's all about equal, equal viewing under the law. If there's a reason why you're protecting these populations, this population is also experiencing those same things. They should be protected as well.
Okay. A PFAC thing I mentioned earlier, and I'm not going to go into detail, I encourage organizations to include the voice of the patient with the planning for these kind of events, as well as in the RCAs that follow up afterwards. You might be surprised with how much you can get out of those kind of conversations. Mindfulness is a key part of high reliability, and I would suggest the most mindful people typically in an organization are patient and family members. Even in the ER, they're sitting there, they're hurting, they're waiting for it to be seen, stress level is high. They may see some behavior in there that they're starting to wonder about, and they may call attention to staff.
Great idea,
Dan. One other quick thing. I'd be interested in what are the most important training focuses that you're promoting in the teaching to upgrade the level of staff, and you train other staff in nearby units to be able to respond. And I would add one more thing. Do you include concealed carry with your protection, maybe by these other staff that others may not even know about?
Rob, do you want to comment, or should we go to Bill on that?
I would kick that over to my colleagues there. I think it's more in their wheelhouse.
So, Bill, I'm watching our time because we always promised to finish on time. Bill, love to have A, your reaction, and then B, just so we are mindful of our audience, address if a patient is confused and assaults a nurse, is the patient still charged with assault? That's a great question. And then Dan's question regarding the concealed carry. But you want to kind of react? How about that question about what do we do with the patient who's confused? And then Dan's question. And then, Vicki, you can pick it up from there. And then we have a couple other questions.
Well, certainly if a nurse is assaulted by a patient, then we'd make a case. And certainly you take into effect all the different parameters that are in play. Again, does the patient still need to be treated? You can't take a patient that's in bad shape, just take them out. What you can do is you can do the proper protection mechanism in terms of how you're going to restrain him or her and so forth, and then you can file the appropriate charges. I also think
and the question, Bill, I think the question Jennifer Booms wants to know is, what if because of the medical condition they're confused, and that's the contributing factor to assaulting a nurse?
Well,
would you still charge them?
Yeah, there still has to be a culpable mental state. So you would have to be able to make that determination, and then that would drive whether or not there could be criminal charges. And so that you look at that, and that would be a conversation with the prosecuting authority. But again, the main thing is to get in there and get the person properly restrained and stop any of the potential dangers, and then get treatment to both the patient as well as the victim of the assault. But I want to go back to talk a little bit about what Mr. Kramer said in terms of the higher charges of felony. One of the things that does in fact do is even though people might be in an emotional state, what it does in advance is that if something does happen and the individual is not there, it does upgrade the quality of the investigation, because there is limited capacity in law enforcement, and they will certainly investigate felonies before they will misdemeanors. So I think that's one of the questions that came up earlier. And the other thing around the carrying of a weapon is, in most cases, that you're just not allowed to carry weapons into hospitals. I can't speak to other states, but I would think in most hospitals. But it is an issue where if you really do your risk and threat assessments that we showed on our screen earlier, and you do them properly, you will have in place mechanisms where you'll have security on site. You'd actually, if someone did come in with a weapon and didn't know they couldn't, you'd have abilities to get the weapon secured, making sure that it's not there while there's treatment and so forth. So we are real sensitive across the board in security as well as law enforcement in terms of people that are carrying weapons, if you will.
Great, Bill. And Vicki, just for time, and I'm going to throw this up to both of you, but Vicki, maybe you respond next so we kind of give everybody a chance. Craig Kennedy asks, what are organizations doing in regard to social media and threats or workplace disputes that are posted on them? And Bill, you and I even have a conversation earlier today regarding these folks that may be out on the web and then defaming others. And this is truly both an insider and an outsider threat. And so those can be contributing factors to bringing on violence, and it's still an abuse of power that can impact the property of the organization, including its reputation. Vicki, you want to kind of pick up on that and then add whatever you'd like?
Right, and that's an important emerging problem that organizations are wrestling with. If it's an open source, meaning that anyone can view it, they're posting it to the public, yes, the First Amendment right is there, but if it's a threat, and a reasonable person would say that that's a threatening communication, then there are criminal sanctions. If it's a reputational issue, then there are civil sanctions. Just because we have the right to free speech doesn't mean that we have the right to no consequences. So we look at social media. There are social media monitoring events. There are tools that can be utilized, third-party tools, to harvest large chunks of open source information that may reference an individual or the institution, and those are truly great for getting ahead of a threat and determining what the problem is that the person has, and sometimes if you can address what their grievance is, then they can withdraw and sometimes help rehabilitate. But we look at it from a threat perspective, and that type of information is invaluable in helping us assess and address the concerns of the target individual.
So, and then if I could expand on the social media part, again, it's not so much the modality as it is the actual pattern and nature. So when we take a look at these particular social media things, we take a look at the context of the behaviors that are being listed there. So, for example, we look at the pattern of communications, the intensity of the focus on a specific person or target. Then there's also the potential for leakage of the intention. So in other words, are they talking outside of the social media to somebody else, which would bring more credence to it? And then also the prevalence of whether or not the contact language is predictive of the fact that they're going to approach the target. In other words, can we see that there's some evidence there that they're going to be some imminence to what their intentions are. So there's a lot of complexities to working through the social media lens too, but it's really a matter of understanding it and harvesting it and looking at it. And like Vicki says, if you're sending it perhaps on a private social media site and it's very specific and it looks like it's going to be something of violence, it's more actionable than just throwing it out to the world and just making a saying that you hate something or that you're threatening an entire state or country or something that's that vague.
We're trying to make a determination, is it a targeted, a very specific act, or was this a shoot from the hip type of outburst, and evaluate what is the sentiment, what is the grievance behind the event to help us evaluate how we can mitigate the threat, maybe talk the person down, de-escalate the issue before we ramp it up with criminal or civil sanctions. But certainly those are in our toolbox if we should need to shut someone down.
Great. I have a quick question now. I want to go to Dan, give him a chance to comment again and ask a question. And I just saw another one. Let me go first to Philip Eberhardt. Do you have a list of states with laws classifying assault on nurse staff as a felony? Is that a place, Rob, where we can find out what states actually do that?
Yes, so we are currently in the process of updating our map that we would normally have on our website.
Okay.
And we will have that up hopefully within the next couple of weeks. It's just a matter of making sure that the graphics are done and all that. So that is in the process of being done, but it will illustrate sort of in the best that we can ascertain. There are a number of different nuances in the law, definitions and things, but this is to the best of our knowledge the states that have enacted felony laws.
Great. So, Kyle, put that link to Rob's site so that we make sure when people go on the landing page in the future on demand when they watch it, that they can go and look at that. So, my question is, do you all think that there might be an opportunity to invite a hospital that started from zero to put together a good workplace violence program? Like what you guys have done at Anderson, and I'll throw this out to any of you guys, where we always love to have a hospital leader come on and say, look, we started from zero and we built our program and here's what we learned and here's how we did it and here's what we did. Because, Anderson, world's largest and best cancer center, is not the same as St. Elsewhere Hospital, 200 beds, limited resources, got to start a program. Boy, it would be great to see what others have done. Bill, do you think, and Rob, do you think we could round up some folks that have put a really, really robust program together?
I can certainly reach out to my members and talk to some of our managers and see who has put in programs that that they would want to talk about. So I can definitely look into it.
That would be awesome because I could see a really good webinar to address that. Dan, do you have any questions or comments of what you've heard up to this point? And I ask the audience, if you have other questions, pop them up on the Q&A. These are good questions, and we'll fire them off to our speakers.
One other one, Chuck. Is there value in learning from the Veterans Administration, the VA, on how they respond to situations like this, situations of violence? And I'm thinking about with the legislation that's going to enhance the blending of VA care in a community with the private sector. And taking that further, I'm thinking that hospitals are going to have to demonstrate that, and again, shorten the time frame from 30 days, hopefully, to much less. There's a waiting period right now in the current choice program. But we're going to have to demonstrate, I would suspect, to the VA that when we start treating veterans more, we can adequately handle situations like this. Now, you're pretty far ahead, Bill, of the country. Go ahead.
Chuck here, having worked as a cancer doctor at a big Veterans Administration hospital in Houston, we definitely had lots of these issues that we saw. We want to thank Rob. Rob Kramer had to go to another very important event. Rob, thank you. If you're still on, if you're not, we thank you for doing a great job. We have 3 more minutes. I'd like to go back to Bill and Vicki for final thoughts before we have Dan close us. Bill, final thoughts, and maybe a little bit about Vicki brought up MedTech and her piece. What you've done with your law enforcement officers there, because you specifically regarding the active shooter. I mean, being involved in the program with Dr. Boats was terrific. I mean, you guys just did a great job.
Well, MedTech is like you said, it's addressing all of the preventative deaths in the workplace, and so we've incorporated that, so it's far much greater reaching than just on the active shooter. And Dr. Boats he's our chief medical officer and medical director here. So I mean he's fabulous. He'd be the person to contact to get a lot more information around MedTech and those things that we support. But in reference to the threat management piece, it's very complex and there's a lot of things that folks need to do. But when you look at the different typologies, you need to have a very robust program with a lot of people involved. Everything from doing quality backgrounds on your employees, even on your contract help. So I just think that there's a lot that we can do. We can develop a community of practice and work together, Chuck, like you said. We'll do what we can to locate some other hospitals that have some pretty robust programs, as you asked.
Fantastic. Vicki, and then Dan will have you close this. Vicki, final thoughts?
Vicki had to step out on a case that just came in.
Okay. Well, we want to thank her, and if you could stay on, Bill, after we always do an after action, how could we do better? Dan, would you please, and again, thank you for helping us focus on VAs as a former veteran, and thank you for that focus. Dan, would you please close us, and then we'll wrap up the webinar.
Sure. I just want to thank everybody on the end of this in terms of participation and listening and watching. Thank you to the faculty. Thank you, Chuck, for your amazing contribution to healthcare with these programs, and specifically to today's, just to help us focus on this really important subject and unfortunately a growing subject. And just wanted to thank you as well, and thank you for including me.
Great. Well, listen, God bless you all, and we'll see you in July.